Dr. Paul Swart will be facilitating the session, so I will be handing over to you now, and the other attendees that are still coming online will just join as they come up. All right, thank you so much.
Thank you, Claudia. I was asked to facilitate this, not because, well, I've given a few talks on thermal endometrial ablation, but we're very fortunate to have Mr. Powell today to speak to us on this webinar that's called Why Endometrial Ablation? Well, why? It's obvious, because we do not have perfect treatment for menorrhagia, heavy menstrual bleeding, particularly ovulatory heavy menstrual bleeding, because the hormones sometimes have side effects and doesn't always work. Neither do the antifibrinolytics. And hysterectomies are quite invasive procedures. Whilst ablation is a minimally invasive procedure with good results and with fortunately few complications. We're very fortunate to have Mr. Powell to speak to us this afternoon. I went through his CV last night, and it is quite impressive. I could count 55 publications in peer-reviewed journals, most of them on minimally invasive surgery. 3 I could find purely on endometrial ablation. Lots of publications in textbooks and posters. He is from the UK, from the Nottingham circuit, and he's going to speak on a few talks: why this procedure, what's the ideal technology, patient selection, balloon versus radio frequency techniques, procedures, and some outcomes. I also would like to thank the people that organized this webinar, which is Sure Medical, which are the people that we work with here, and Idoman. The one wonderful thing that I think will come of this COVID thing is that this sort of teaching opportunities I find fantastic, and will be a boost to continued medical education. I'm going to ask Dr. Powell to continue with his talk. At the bottom of the screen, you'll see a button that says question and answer, or another one that says chat. If there are any questions, click on one of those, and I think you can click on either of those, type in your question, and we'll see if there's time at the end of the talk to discuss some of these things. And that, I think, over to you, Mr. Powell.
Thank you, Dr. Swart. I think you're right that this way of education and communication is going to be one of the maybe few good things that comes out of this COVID crisis that's affected almost every corner of the world. And I think that this will be a change, and welcome change, although personally I would have preferred to have been in a lovely city like Cape Town or Jerusalem, which I think we have quite a few Israeli doctors as well, talking to you all in a lecture theatre, and then being taken out to a delightful restaurant in your various cities and being wined and dined. Instead, we have to do it like this. I have some disclosures, and I would say to you all that the value of the companies and the representatives such as Claudia who come to see you, I've always said to my staff that you should always welcome them into your office. And they are often people that will give you the first insight into new concepts of the way you manage things. So Gideon Richter, for example, I did a lot of work with them for ESMIA, the progesterone receptor modulator. For Medtronic, I did also some work with the Smith & Nephew morcellator, Nicomed for the filter clip sterilization, and Lina for the tension-free vaginal tape. all of which really started by people coming to see me and saying, would you like to do this? What do you think about this as an idea? So what we're going to do this evening is to look at a thermal endometrial ablation, talk about endometrial ablation techniques in general. So those of you that don't know where Nottingham is, it's slap bang in the middle of the United Kingdom. And this is a picture of where I worked, which is called the Nottingham Treatment Centre. It's purely for outpatient, day case and some inpatient procedures. And it was initially run by a company called Circle. You can see their logo in the left-hand corner. And so they were a private company running a hospital for NHS patients, which was an interesting concept. One of our governments in the past that was brought this forward. And what it meant for me was that when I was looking at trying to finance things like development of more rooms to work in, I had easier access to that than I would have had if I was working over the road in the main hospital. So why would we want to do an endometrial ablation? Well, I hope to all of you, this is straightforward. When I was an SHO many eons ago, I remember wondering why this normal-sized organ was being removed through a big incision. And I think by choice, a lot of women would not have that done, but on the other hand, they want to have a solution to their often very troublesome problem of having heavy periods. And the endometrial ablation is such that, as I say, that most cases they will be able to return to normal activity the next day, whether a general anaesthetic or outpatients. The complication rate in the short term is very small. It avoids hysterectomy, should we say at least in 80% of cases at the bare minimum. Most patients are not necessarily looking for amenorrhea, which I'll talk about in a minute, but they want to avoid having hormonal therapy or certainly not major surgery. So what is the concept that we're trying to put across when we do an ablation? We want to destroy that subendometrial layer of glands, which extends 5 millimeters below the endomyometrial junction. And all devices involve these three concepts of time, temperature, and pressure. So what we have to do is use enough time for the heat to have its effect on those tissues. We want the temperature to be high enough not to cause scarring and charring, and not too little, obviously, to not have any effect. Pressure is, with the balloon ablations, is very important because this stops the blood flow, the subendometrial blood flow, and allows for transfer of the heat. So we want our ideal ablation technique to provide maximum safety, to be under our control, to do what we want it to do, and effective in destroying the endometrium and reducing menstrual loss to normal levels. Because after all, there are things that we maybe have done in the past that worked for a while and then they didn't work afterwards. And even if a device seems very clever and organized, it's got to be worthwhile doing on the long term for cost, for economic costs. So again, what do we want to try and achieve when we do the treatment? It's true that there has been an argument to try and get amenorrhea, an absence of periods, because maybe people looked on the ablation and the first generation devices as being a replacement for hysterectomy. But the problem about amenorrhea, as you can see, is you can get this condition called hematometrius, which are a nuisance and a cause of quite severe pain post-ablation. You have this tubal sterilization syndrome where women have been sterilized. There's then retrograde menstruation, which then gets stuck at the point of sterilization. And there's this concept that if you are not menstruating, do you delay the diagnosis of endometrial cancer? And again, that's something I'll talk about later. So is it better to not necessarily stop the periods, but reduce the periods back to a normal level? So heavy menstrual bleeding, so in other words, regular menstrual loss, is the ideal scenario for a person having ablation. Obviously in the UK, and I'm sure it's the same in South Africa and Israel, you have guidelines from your respective colleges which suggest a course of management of these women with heavy menstrual bleeding. And naturally, we're talking about tranexamic acid, methylamic acid, we're talking about Mirena, we're talking about pills, contraceptive pills, depending on their fertility status. So lots of things before we even get to that point of offering an endometrial ablation. So as I've said in that final point, it is a failure of medical treatment. So women come to you because they don't like that continued bleeding they're getting with the Mirena. They don't like the side effects from the contraceptive pill. The tranexamic acid doesn't reduce their menstrual loss to the level that they wish. Now, obviously, if a lady has an ovulatory bleeding, so in other words, she has more prolonged menstrual loss, it's a bit more difficult because you might then give a lady a very light, but still a prolonged menstrual loss, and they've got to be aware of this. Fibroids up to a type 2 are not contraindicated. Obviously, the procedure retains the uterus, but on the other hand, the women have finished their family. So the first balloon ablation, that again, you may be aware of, was the Thermochoice that came in 1994. I remember going down to Birmingham to see the Thermochoice used in a sort of outpatient scenario. It was at the end of a ward. The patient had IV analgesia and sedation. And of course, the procedure lasted 8 minutes. But the concept was a temperature of 87, a pressure of 160 to 180. And you remember that often, I certainly remember being left to do this while someone else walked out of theatre, and because of that time of 8 minutes and needing to keep the pressure up by adding more and more 5% dextrose. One of the advantages of it was that it was 3 millimeters in diameter and 16 centimeters in length. So in some of the difficult patients, it was very easy to use. Unfortunately, it is no longer available. NovaSure, you will have heard of, again, a radiofrequency ablation. Again, it fulfills one of the criteria that I'm looking for in terms of a short treatment time. And I have used NovaSure. The problems I've personally found with it are that because of the integrity test, even with a cervical cap, it's sometimes difficult to achieve that integrity, and the machine, of course, will not operate unless it feels it can maintain that pressure within the cavity. The concept of the procedure is different in terms of balloon ablation, and the tissue is vaporized and then removed. Again, the cavity has to be of a certain width and a certain size. Some of the problems long-term I found with the NovaSure, again, we'll mention later. So I've used the Thermoblade since about 2006. And I liked it because, again, it has a short treatment time. a higher pressure and a higher intrauterine temperature. And this is how it gets around the shorter treatment time. It's a 6 millimeter diameter probe, and it is light, it's very easy to use. The probe, of course, is disposable. To have a look at it in a bit more detail, this is the cartridge, the disposable cartridge, which gets inserted into the main unit, and it has a maximum capacity of about 25 mils. So this is a control unit. You can see there's a treatment switch in blue and an emergency stop button. Now, I've done over 1,000 of these thermoblations, and I've never had to press that red button. I'm not saying that, and I've done all these in outpatients, I might say, and I'm not saying that patients didn't experience some pain during their ablation, but of course the treatment time is so short at 2 minutes and 6 seconds. Usually with very good nurses, those patients that did find it uncomfortable would have persevered till the end. So this is a diagrammatic illustration of what is happening during the course of ablation. There are cycles of treatment, 3 cycles of treatment, where the fluid is exchanged within the balloon to keep it hot. You can see that the blue line is the temperature within the control unit, which is about 173 degrees centigrade. Whereas the red line is the temperature at the balloon surface, which you can see is just less than 100 degrees centigrade, around 93 to 94 on average. And so this again is shows the timing of the procedure and the mixture processes. So when you do a radiofrequency and ablation and you do a thermoblade, you have, because they're different, you have different changes in the appearance after you've done each of the procedures. And I'm sure those of you who have done both will recognize these things. So that the outward pressure causes the tissue in the balloon ablation to become white and blanched. And I have in my life been called to the ward the next day when a patient was admitted with what appeared to be, according to my junior medical staff, urine coming from this patient's uterus, thinking that I'd obviously done something pretty awful when I'd done the ablation. The fluid sometimes, it's rare, but coming from the ablated cavity can be quite serous. From the radiofrequency, there's a much more charred and blackening appearance. And so this is the appearance after a thermoblade, and you can see the white blanched effect. Colleagues have commented about the fact that the balloon does not go into the ostium, and would that potentially be a problem? Now, my experience is that isn't the case, and also my experience with the NovaSure is you can get something very similar. But this is the appearance of the NovaSure ablation, which, as I say, is completely different, and that does have some long-term effects which are important. So in terms of patient selection, it's important if a patient, although their family's has been complete, but neither they or their partner is sterilized, excuse me, that you talk to them about contraception. I'm keen to insert a Mirena if the patient consents, because there is some evidence from Canada that this increases the success of your ablation. But as I said earlier on, a lot of our patients have been fed up with a Mirena, and that's why they want to have an ablation, and they don't want another Mirena put in. But as I said, it's important that they do have are aware that they still need to take contraception. I do remember another patient of mine who was coming for an ablation, and I said, "What are you doing for contraception?" She said, "Well, my husband's had a vasectomy." But she then came to see me about 3 years later, having had a miscarriage because she changed her husband, who had not had a vasectomy. So maybe I didn't counsel them really as completely as I should. So caesarean sections, I know that in the UK our caesarean section rate is heading over 25%. My guess is, or I think I do know that it's high in South Africa. I don't know quite what it is in Israel. But up to 3 caesarean sections are not a contraindication. Between me and the 100 delegates that are there tonight, I have done one on someone that's had 4 caesarean sections. She came up to clinic when I was away, expecting to have an ablation, and then came with her husband 2 weeks later, expecting to have the ablation, with her husband looking quite cross. And so I went ahead and did the ablation. She was fine, but the rules are no greater than 3 caesarean sections. Obviously, we want to check the endometrium is healthy, that there's no hyperplasia or cancer, that there are no polyps, the cavity measures as we'd expected, that they've got a negative pregnancy test, they have the right sort of fibroids, that they haven't got an abnormal shaped uterus. Adenomyosis isn't necessarily a contraindication, but obviously if the patient have adenomyosis, my concept is that their type of symptoms they're presenting to you are different in terms of the fact that pain is more a predominant feature than heavy menstrual loss. One of the good things about the thermoblade is that cervical laxity is not an issue. And as I mentioned earlier about the radiofrequency ablation, trying to get that integrity test, sometimes that's very difficult with women with lax cervixes. Again, I mentioned with the Therma Choice, which we can't use anymore, that it has a very thin catheter and very thin unit the catheter goes into. So that whole thing could have gone inside the vagina. The thermoblade catheter is 18 centimeters, and it's possible in women with very high BMIs and no descent that it's not possible to use the thermoblade because of the length of the vagina. So my protocol, and this doesn't matter whether it's under general anaesthetic or local anaesthetic, is quite simple. So the first thing I would do is have a look inside my uterus. I might have done that before when the patient first came to see me, but I would still do that every time I'm about to do an ablation. It tells me that there's nothing inside the uterus that I need to be concerned about, that might affect my ablation. And it also tells me exactly the direction of the cervical canal and its relationship to the uterine cavity. I then measure the cervix to fundus with my Powell endometrial aspiration device. I will take a sample, but I would hope that it had already been done before I went ahead with the ablation. But it measures for me exactly the distance from the cervix to the fundus in a non-invasive way. I then dilate the cervix, if I need to, up to a 6 or 7, put my balloon in to exactly the depth that I've measured and its direction, and then complete the ablation, and then repeat the hysteroscopy. I want to look, I'm interested to see what effect my ablation's had on the uterine cavity, and of course to inspect the integrity. In our outpatient clinic, the patients rest about 20 minutes to half an hour before they go home. Ideally, they wouldn't drive themselves home, but occasionally they have done. And then we telephone them the next day. So just to give you a background halfway through to myself and the sorts of things that I've done in my life. So I was appointed in 1993 when we set up a outpatient mental disorder clinic. We use one hysteroscope, a carbon dioxide to distend the uterine cavity, and a jar of Sidex to re-sterilize our hysteroscope. I had to fight hard to get the Mirena inserted in 1996 for women that had heavy periods, but that was my first success. We then used the VersaPoint in 1998 to remove polyps and treat fibroids. And then in 2004, we did our first outpatient endometrial ablations. When we were 2010, we changed completely, didn't put a speculum inside the vagina and used the vaginoscopic approach. And then in 2014, we started to morcellate polyps and fibroids in outpatients. Those of you that don't have that facility, I can tell you, one, it's very enjoyable as a surgeon to be able to do all these things in a challenge, to be able to do all these things in outpatients without, with the patients all going home and obviously not causing your patients severe pain. There's a website in the UK that's set up by patients about painful hysteroscopies in outpatients and how people shouldn't do them. But I probably have one complaint in all of my time of doing this, and I probably do 300 or 400 cases a year. So what do you need? We have 3 rooms, like the room you can see there. It doubles for a colposcopy. You can see the colposcope in the corner. So our staff, are looking very beautiful, except for the one on the right-hand side, are trained to look after women who are having outpatients procedures. And I've got a trainee on the left there now, a consultant. We have nitrous oxide available, and we analysed all our results before we went ahead. And I'll show you something about that in a minute. So it's very important. Hysteroscopy is very important in terms of doing the ablation, and before and after, and you can't do that. You shouldn't do ablations without doing that. And it tells you all those things that we've mentioned. So just again, briefly, these are the instruments I use in outpatients. On the right-hand side, you see a gas hysteroscope, 3.7 millimeters, which is my diagnostic one. On the left hand at the top, you see this Smith & Nephew Medtronic scope for removing polyps and small fibroids. That's 5 millimeters if you leave off the outside sheath. And then you have another hysteroscope made by Wolf down in the bottom corner, which again is 3.7 millimeters, and it has an inflow and an outflow and an operating channel, which is quite amazing for 3.7 millimeters. That's a picture of our endometrial aspiration devices, which we use for patients over 45 and having some irregular bleeding. All our patients will have an ultrasound in hospital if they haven't had one in outpatients before they come to see us. So just, as I say, to show you how easy it is to do this in outpatients, and maybe in the non-COVID times, you'll kindly invite me to come to Jerusalem, Tel Aviv, Cape Town, Durban, Pretoria. I'm quite happy. I don't mind where I go. And we will enjoy an evening meal after I've watched you do an ablation in outpatients. So we do an intracervical block with mefloquine. We use dental syringe. We have nitrous oxide given at the same time, and I put in some instilled gel. So if you were asked to look at your own patients and determine what made a success and what was likely to be a cause of failure, you'd say, well, this is the sort of thing that we would expect. So older women rather than younger women, women with smaller cavities, more symptomatic, lower hemoglobins, women of a higher social class who appreciate maybe wanting to keep their uterus and not wanting to have a hysterectomy and be done with it. And then you have those other negative factors such as dysmenorrhea. And I always think it's very important when you are talking to patients to understand the relationship between pain and heavy bleeding. So for instance, clot plain. as an example, their menstrual loss is heavy at the time of the greatest pain, rather what I think of as adenomyosis pain, where the pain is greatest, disproportionate to the heaviness of the menstrual loss. This was a study we did, we published in 2008, where we looked at 100 patients who had an outpatient endometrial ablation, and we asked them, did pain scores all the usual thing? And that was from that point that we then went forward and did the other study. We then looked at all our patients. We had about 150 patients in each group who'd had an oversure and a thermoblade. And we did that retrospectively. It wasn't a randomized controlled trial. And we looked at the common factors. So thermoblade, and does vary from study to study, but this was our own study, had a lower amenorrhea rate than I'd anticipated. But when you add the two figures together of amenorrhea and lighter bleeding, and with the radiofrequency, the amenorrhea and the lighter bleeding, they come to very similar results. In fact, the thermoblade is better. What is the interesting thing is the cyclical pain you get after the radiofrequency ablation. So then looking at these results in a more diagrammatic way, one of the important things is then to see the hysterectomy rate, and these are 5 years. So you can see the hysterectomy rate for a radiofrequency ablation was 10% higher than what it was for the thermoblade. This is another study which had 50 patients in each group, and compared microwave endometrial ablations, intrauterine devices, and the NovaSure. And you can see that they're similar results, a lower hysterectomy rate in the radiofrequency ablation than we found. But the results are not dissimilar. Amenorrhea rate with the radiofrequency they found was 36% as an example. So you will find differences. Long-term studies that have been available, this is with the Thermojoyce, offers balloon ablation. You can see that, again, a higher hysterectomy rate with the radiofrequency ablation or bipolar, but very similar success rates. So what about the complications? So you have immediate complications in the short term of cramping and pelvic pain, and we've had some patients that have had to stay longer, maybe an hour, because they've been in pain or they felt sick. We talked about vaginal discharge, and unfortunately, I mean, I've had one patient that's got pregnant who had a miscarriage, but in another hospital in Nottingham, they did have a major complication when somebody got pregnant, unfortunately. Infection, I have not seen a woman that's had infections after thermoblade in all my patients. Hematometra does not occur with the thermoblade because it does not cause obstruction of the outflow, but it does happen. Uterine perforation, I'll show you an example of that. That is a risk. Again, if you follow the technique that I've described precisely, then I don't believe it will happen. And then these tubal sterilizations and vesical uterine fistula, I mean, are very rare. So this is an example that I was sent for an opinion, not medical legally, but I was sent for opinion as to why this had happened. Now, unfortunately, this patient was dilated before she had a hysteroscopy, and that made a hole, and you can see right in the center, not where the arrows are, someone else's arrows, and you can see that what's happened is the balloon has come through that perforation made by the dilators. So you can see the white area on the edge of that hole. Now, again, that was a technical error rather than with a thermoablation, because the general surgeons, being general surgeons, had to make sure, as they do, that there was nothing else going on at all and there's been no other damage. So needless to say, she had a laparotomy, and I've no doubt she sued that doctor. This is the MHRA, which looked at thermoablate and found the incidence of these complications to be very small, assuming that you follow this protocol very precisely. So the hematometra, which we mentioned, so you know what a hematometra is, and this is an example of a patient who had had a radiofrequency ablation. And again, I don't know how many of you have seen this. This was under a general anaesthetic when I was trying to get into this uterine cavity. And the problem with the radiofrequency ablations is that they, by the nature of the technique, they stick the anterior wall to the posterior wall. Now, you might be a cleverer surgeon than I and are able to get your hysteroscope inside into that uterine cavity. And I've certainly seen, when I've been working in another country, some very, very able hysteroscopists who use ultrasound during the general anaesthetic to guide them into the uterine cavity. But this is the problem of accessing the uterine cavity when someone's had a novusure. Now, obviously, this patient didn't come to me with no symptoms. She came to see me because she had a bit of irregular bleeding and she'd had severe pain. But to me, this is a big issue. So going on really to, again, address this directly, there was an article published a couple of years ago where in America, and these are novusure ablations, they are going to have surpassed the number of women having hysterectomies. And of course, they've been around a long time. And so this author, who was an oncologist, proposed that this might be a problem in terms of the diagnosis of endometrial cancer. And they worried about patients who were asymptomatic but had developed new pelvic pain, so had no bleeding, which we would characteristically associate with endometrial cancer. And as I mentioned, having a hysteroscopy under those circumstances is very difficult. And they even argued that these patients should have a hysterectomy. But there have been other studies, one a long time ago after first generation ablations, and then another one by Cooper in 2011 that showed that there wasn't an increase in endometrial cancer. But it is a theoretical risk, I think, rather than a practical risk. And if you carefully select your patients, and so that you're not doing those with endometrial hyperplasia, as an example, as there were some in one study, or they're highly likely to develop endometrial cancer because they have or at risk of developing endometrial cancer because they're diabetic, polycystic ovarian syndrome, and very obese. You still have to determine how you're going to manage that patient who has all of those problems, because they're not necessarily easy to deal with by major surgery. So pregnancy, this is typical, isn't it, of, I'm afraid, potentially women requesting this type of surgery when their families are hardly likely to be complete at that age. But they cause major problems, pregnancy in these sorts of patients. So I want to go on and talk, because we're getting near the end of our talk, about first generation resections. Now, Adam Magos, who all of you will have heard of, did these under local anaesthetic of some form or another way back in the late 1980s. And I always enjoyed doing an endometrial resection because I felt it required a certain amount of skill. And of course, when you learn to do this technique, it then means you can deal with fibroids, and it teaches you how to deal with large fibroids. Now, Medtronic and Hologic have developed methods of hysteroscopically using their morcellator, dealing with certain fibroids, but they can't deal with the nature of the fibroids that we sometimes get confronted with. And I'm sure it's a problem in South Africa, where you need to resect them. So I think you need to maintain that skill, even though secondary generation ablations are around. So it is difficult to teach a resection, a primary resection. Our junior medical staff, sometimes they're in the same one as in theatre with you, sometimes it's a different one, and actually teaching your junior staff to learn this technique is difficult. One of the reasons why second generation devices such as the Thermoblade were developed was because of the complications which were identified in the Mistletoe study in 1994, where patients unfortunately were having in 2.5% uterine perforations with all the consequences of that, or worse, they were having fluid overload with glycine. However, you are able to deal with larger cavities, remove fibroids at the same time, and of course it's reusable. And if you happen to be in a hospital where they don't want to spend a lot of money, then you might have no alternative but to use the resectoscope. Of our ablation, it's easy. So every Thermoblade takes 2 minutes and 6 seconds. It is so easy to teach. In our hospital, we have two what we can now call nurse consultants that do these ablations. You can use them in the office or day surgery, but they do cost. Obviously, it's not available in every country, and the technique is blind, but if you are very careful in how you use this device, it shouldn't be an issue. When they are compared, that's first generation and second generation, they have very similar results in terms of patient satisfaction and a long-term follow-up. So I think we can agree that there is no disadvantage to using second generation endometrial ablation devices, and a significant proportion, and as I say, I did all of mine, as many as I could anyhow, under local anaesthetic. So this was a study, summary of the patients looked at in various trials and looking at the complication rates associated with second generation versus first generation devices. And it was this perforation rate, which really, as I mentioned, did lead to the second generation endometrial ablation devices developing. Now, so I think we're on conclusions now. No, that slide has come a bit too soon. So this is, again, by Kevin Cooper, a very well-known endometrial resection ablation expert, who wrote a review paper in 2017 that last table was taken from. And you can see that in his view, and it's certainly my view, that the offering of an outpatient ablation technique should be a long-term goal for all of your hospitals. And the ThermoBlade is an ideal ablation device to be able to do this. Although, of course, as I say, it can be done local. This was me in somewhere in China. I can't quite remember where it was. And I gave, I went around a number of hospitals talking about ThermoBlade. And I would often have to do ablations after I'd given the lecture. And of course, 9 times out of 10, they were done under general anaesthetic. So I gave this lecture in a lovely hospital. And I finished the lecture. I went upstairs to be told I was doing these patients a week under local anaesthetic. So I thought, great. And I was expected just to go in and do these procedures without having seen the patients, consented them. So I said, whoa, I said, you know, I need to see these patients first of all. And there were 2 patients. But when I'd seen them and consented them, felt they understood what they were going to do, this young doctor, who was a trainee doctor, wasn't a consultant, said, well, are you going to do these patients, Mr. Powell? I said, no. I said, you're going to do them, and I'm going to show you what to do. And this young doctor carried out, as far as I know, one of the first local anaesthetic ablations in China. It's a huge country, so I can't say that categorically, but wherever I went in China, they didn't do locals. And he did it extremely well. And so what I'm put that up really to tell you, apart from the story, is that it's easy to do, it's easy to teach. And that comes down to the nature of the ThermoBlade. That when I first looked at the radio frequency ablation device, I thought, goodness me, this is complicated. It's not actually as complicated at all, but when I'm just looking at it, and it has all these other bits you've got to think about. Whereas with the ThermoBlade, it's very straightforward. So this is my final slide. I think we're coming up to our 45 minutes, maybe we're a little bit over. And really summarizes what I think is important. And we do realize that 100% of patients are not happy with ablations. But one of the reasons why ablations, primary and secondary, developed was about the risks of patients having hysterectomy. And I'm sure that those of you who've done a lot of hysterectomies will empathize with me and with your colleagues that sometimes there are complications that you didn't intend or wish to happen to patients who've had a hysterectomy. And if you can do a technique which allows, as we say, 80 to 90% of patients to be happy with the end result of your intervention, safe intervention, that you can use either in outpatient or operating theatre, then I think you have a technique that you should offer patients. I might say, with all this COVID business going around, that from the anaesthetic point of view, if you can put your local anaesthetic probably maybe not a meter away, but a certain distance away from a patient coughing, then it's probably a safer way of dealing with a problem at the moment than expecting your anaesthetic colleague to give an anaesthetic to patients. So I hope that has been a a nice start to all your evenings, wherever you are, and what your next steps are going to be. And I look forward to any questions you'd like to ask me. I'm quite happy to stay here for the next hour, if necessary, answering questions. It's not that I don't get the opportunity often to talk to so many doctors at the same time. So I'm quite happy to stay here and just answer questions until you all get fed up and want to go home and have your gin and tonics. Dr. Swart.
Thank you very much, Mr. Powell. I think it was an excellent presentation, and I would have given you a round of applause if I was in a face-to-face meeting. There are a number of questions. Some of them I'm sure you have answered.
Okay.
But let me go through a few of them. There's a question from a Dr. Sikakani on your views on failure rate. And obviously the question would then be, what is a failure? It's probably when the patient isn't happy. But the more interesting is your indications for a repeat ablation.
Okay, so thank you. I wouldn't do a repeat second generation ablation. Now, I'm not saying that people around the world haven't done that, and certainly they didn't have done that in China. One of the nice things about the Thermoblade is, as I mentioned, it doesn't destroy the uterine cavity. So you can get back inside the uterus. So if a patient comes back to me and says, which of course they have done, I'm not happy with what you've done for me as an end result, then what I would have suggested to them is that they have a short general anesthetic, and I would have resected any remainder of the endometrium. The problem with the radiofrequency bipolar Novashore is you can't get in the uterine cavity, or 9 out of 10 times you can't get in the uterine cavity. So it's very difficult then to offer them something else. But I don't do repeat ablations.
Thank you for that. My good friend Oscar Shimange wants to know your opinion on 1, 2, or 3 previous cesarean sections, which you have covered. If you see low transverse isthmoseals in the uterus in the previous cesarean section patients, are you intimidated by those ultrasound scars that you can sometimes see in patients, even if they had less than 3 cesarean sections? I'm not talking about classical incisions, which in any case is very rare, that can be very low, but with a low transverse incision that can sometimes be quite impressive, the gap.
Okay. It's true that this nidus that's been identified in the cesarean section scar was something I hadn't really heard about till I went to an AAGL meeting a couple of years ago, and they were all resecting the, I will not say all, there was a surgeon who was doing this very clever resection laparoscopically of the old scar and resuturing it. Now, I have been doing ablations on women with uteruses, with cesarean section scars, and I have not asked my ultrasonographers since 2004 to measure the thickness of the uterine wall in patients who've had cesarean sections. Because it's that old thing about when you have had a woman deliver by cesarean section and your junior doctor says, oh, shall I just examine the woman to see whether the scar is intact? And you just don't do that, do you? You don't do that examination. And so when you think about where the scar is in the uterus, and obviously there is no lower segment in the post-cesarean section uterus, it's very low down, and the balloon is in the upper 3/4 of the uterus. So if someone has had an ultrasound, or I think they've got one of these niduses, then of course I would be reticent to go ahead and do the ablation on her. But as I say, the current guidelines, and I've done this, is no more than 3 cesarean sections.
Dr. Powell, can you still hear me?
Yes.
Okay. You know, your picture, your video just froze for a second.
Okay, is it going now?
Yeah, it's fine.
Yep. So any more?
No, thank you very much. That was helpful. There's a question from a Dr. Rafiq Balamia that speaks to preparation of the endometrium before the ablation.
Okay.
I know long ago when I still did resections with both the roller balls and the loops, we did it with GnRH analogs and Depo-Provera. Do you have any advice on what the state of the art is?
So it's not necessary to prepare the endometrium. The endometrium is very soft. It's like cotton wool. It's if you've ever done a hysteroscope and thought, well, where am I? And you've just gone into the endometrium. It is so soft, as is appropriate. So when you blow up a balloon inside a uterine cavity, you squash it. So it doesn't matter what time in the menstrual cycle you do the ablation. And we have actually published a paper where we, again, retrospectively, where we saw that the results at any time in the menstrual cycle, it didn't matter with the Thermoblade.
Thank you. There's another question by Dr. Shimangi on prophylactic antibiotics. And he asks, if so, what? I definitely do not use prophylactic antibiotics, and if there's an infection, then I would obviously treat it before the procedure. What is your opinion on that?
Okay. I have thought about it. It's not that I hadn't considered it. And it may be that there are areas in a country where there's a higher incidence of pelvic inflammatory disease, and under that situation you might need or might feel it correct to give some covering antibiotics. As I said in my talk, I've not had a case where someone has had endometritis in all of my cases. Obviously, if they have symptoms that would suggest they had a infection, then of course we wouldn't treat them. There may have been patients that have had infections and we've just not been aware of them, and we've treated them. But it's not been a problem. But I mean, I would use some broad spectrum antibiotics if I was going to cover them. And again, if it made you feel more comfortable as a surgeon doing it under antibiotic cover, there is no problem with that. All I just say is that it's not in anybody's protocols, and nor is it in our guidelines in terms of, even when we did primary resections, we didn't used to give antibiotic cover.
Thank you. There's a Dr. Hintz that asks about whether a previous sterilization should be a contraindication, obviously in view of the post-ablation sterilization syndrome.
Yeah.
I do not think so. I sometimes do sterilizations during the procedure, but I would love to hear what your opinion is.
Yeah, I would agree with you. It's, as I said, a theoretical risk, and it obviously has been seen in patients, and it has been assumed that it's retrograde menstruation, as I mentioned, that was getting stuck proximal to a Filshie clip, to an obliterated tube. Again, I don't know what the evidence for that is, but maybe 30%, 40% of women are sterilised in this country. And we've certainly not, again, had a problem where, let's say, a woman complained of unbearable pain, and we found it to be due to a dilated fallopian tube post an ablation. I've not, again, come across that. Say when I've laparoscoped someone who said they've had new pain. I've not seen that, but it is described in the literature, so I have to accept it. But I just think it's a very infrequent complication and not a contraindication to doing an ablation.
Thank you. There's a question on how sensitive the thermoblate instrument is to pick up a perforation.
Okay, so it doesn't matter really what you do, because sometimes somebody will use their Keelan's forceps and do something wrong because they use it inappropriately. So it's my view that if you follow that protocol very precisely, doing the hysteroscope before and the hysteroscope after, measuring the uterine cavity, selecting the right patient, inserting the thermoblate to the right depths, you won't have a perforation. And that example that I showed you and other examples that I've come across in my career have been because people have either chosen the wrong patient, wrong type of patient, or they've not done the technique, because there's no doubt that if you do put your ablation device or your radiofrequency device into the uterine cavity and through the other side, it will be a problem. But of course, again, as I mentioned, there are problems in doing a hysterectomy as well, perhaps of a more major degree. But it's using whatever tool that you get given to help women in whatever specialty. It is being trained how to do it. So, and as I said, I'm more than happy to come out to anywhere in South Africa and train. That would be my pleasure. And so watching somebody do, or somebody watch you do the procedure and go through a proper training. And then once you have gone through that proper training, then maybe getting someone like Claudia to come and sit with you and watch you then do some ablations, and then you'll get the confidence to do the ablation and feel that it's a safe thing for you to do. As I mentioned with the NovaSure, it is a problem with that uterine integrity test, and there still have been complications with the NovaSure as well in terms of perforation.
Thank you. And there's a question by Dr. Desai on whether this is an appropriate emergency procedure in a patient that has profuse vaginal bleeding. I assume, probably speaking on patients on anticoagulation of sorts. I suggest it is an excellent treatment as long as one would then rather just not use the rollerball or resectoscope techniques, but your opinion would be valued.
Okay. If all things being equal, i.e. She has finished her family, has no desire for future fertility, there is no reason why you shouldn't do a thermoblate on that patient. There's no contraindication. And you don't necessarily, if the woman is on anticoagulations, you wouldn't necessarily need to reverse the anticoagulants either. You could just do the procedure. There hasn't been, to my knowledge, a series of 20 patients where the patients had an emergency ablation because of the severity of bleeding. And we've certainly, as I'm sure you have as well, come across patients that are bleeding postpartum, and you wouldn't use it under those circumstances, of course. But if you didn't have access to a thermoplate, then yes, you could do a resection. Your difficulty, a primary resection, your difficulty with that, I would say, is getting a clear view if there's quite a lot of bleeding, and then you'll worry about the extravasation, even if you're using normal saline and bipolar, the extravasation of fluids through these very open vessels. So I would have thought something like an endometrial ablation, thermal endometrial ablation, would be an ideal thing to use.
There's also a question on just your opinion on whether adenomyosis would be a contraindication. I don't think it is, as long as pain isn't a significant part of the symptomatology that the patient presents with, and there might well be a lower success rate in the patient with a really large uterine cavity due to adenomyosis. Do you agree with that?
Again, I agree. Adenomyosis, that's a lecture on its own, a very interesting condition. And obviously it's one of those, the more your pathologist looks for it, the more you find it. And what is the purpose of adenomyosis? Why does it happen? But Dr. Swart is quite right. It depends what symptom bothers a patient. So I will say to a patient, when they say they have pain and they have bleeding, I'll try and determine the relationship of the bleeding and the pain. I will then say to them, maybe, well, if you had a choice, what is the problem that you're most wanting to be dealt with, the pain or the bleeding? And they say, it's the pain, Mr. Powell, I just can't cope with the pain. Well, if I don't think that the pain is related to the severity of the menstrual loss, then I'll perhaps be laparoscoping that lady. I might be scanning her, might be doing some other imaging to try and determine whether she has adenomyosis. And of course, I would be advocating her to have a Mirena, which is the perfect management of patient with adenomyosis, in my opinion. If she said, no, I want this ablation, my best friend has had the ablation and she says it's marvelous, well, I would say to her, okay, I don't mind doing that, but it's going to help your pain more than your bleeding. But it may be that by controlling the bleeding, which maybe is a lesser problem, a patient is more able to cope with her pain, and she's happy. She can cope with the pain. What she couldn't cope was having pain and bleeding. So it's not a contraindication. It just involves more careful counselling.
There's a question from Dr. Smith that says, it sounds as if you are in favor of balloon methods and really found them superior to the radiofrequency methods. He then asks, would you then rather advise us to use the balloons rather than the radiofrequency methods of ablation?
Like I mentioned, I have looked at both of the techniques. And remember, my driving force was, what technique can I use in outpatients? So immediately when someone came to demonstrate the thermoblade, I thought, this is the technique that I want to use. I have used the NovaSure in outpatients and find patients get more pain than what they get with the thermoblade. So that's why I have used the thermoblade. But again, as I mentioned, one of the problems that I found, and we're doing a study on this at the moment, is that 20 patients we've looked at who've come back with a problem. A bit more than that, actually. I think there were 15 Novashores and maybe 12 thermoblates who came back with some bleeding, some issue. Well, 13 out of the 15 Novashore patients, I couldn't examine the inside of her uterine cavity. And I wanted to do that. Maybe she might have been perimenopausal. I wanted to get a sample from inside the uterine cavity, and I couldn't get in the uterus. Whereas all of the patients that had a thermoblate ablation, I could get into the uterine cavity. So I like it. I like it for that reason. I think it's easier to use. It's very easy to teach people how to use it. But if a woman comes to you and says, oh, I never want to have a period for the rest of my life, I worry about her as a patient. But some people would say that having a radiofrequency ablation is more likely to give you amenorrhea. But as I said, that is a particular problem. So sometimes a hospital will have an agreement with a company and you have no choice but to use one device or another. But if I have a choice, and I had a choice, then I would use thermoblate, and that's my recommendation.
Thank you. There's another question on evaluating how effective your procedure was at the end of the procedure, if there's any way that one can do an assessment after the procedure immediately. I presume the question is and see what the chances are that this is going to be successful.
Yeah, so I do, as I said, I do a hysteroscopy immediately after the procedure for two reasons. One is, yes, to have a look at what the uterine cavity looks like. Do I have this typical blanched appearance? Because obviously I have to put my balloon into the right part of the uterine cavity and not have it too low down, but have it right at the top. So I want to look to make sure I've made a complete and correct operation. So that's what that tells me. And I also obviously want to make sure, as a post ablation safety check, that I haven't perforated the uterus. Would I, if I did a prospective study, be able to hysteroscope patients afterwards and predict their long-term outcome? How many I think would be happy, how many I think would be unhappy. But as you know, 15% of patients will have a menstrual loss over 130 mils a month, and they're quite happy. And they're not bothered about that loss. And 60% of patients who have a normal menstrual loss are sitting in front of you in your clinic saying they have heavy periods. So you have a problem overall with the management of menorrhagia, in respect that it's subjective, and we certainly, as male and female gynecologists, could never argue with our patients when they say they have heavy periods that is dominating their life, stopping them working, affecting their sex life, making them feel depressed. Even though you look at that hemoglobin and you see that it's 14.5, you still have to accept and treat that problem. So in other words, I might look inside a lady's uterus and think, oh, I'm not happy that it's got the fundus. But I don't really know whether the reduction in the menstrual loss that I will have given the patient by treating the uterine body will be fine for her. I will have other patients, I know I've had other patients, I look and I think, this has been an amazing result. Not amazing, this has been a typical result. And I've ablated everything that I thought I should ablate. And she comes to me and says, I'm not happy, Mr. Powell. So that's the vagaries of being a gynecologist.
Thank you very much, Mr. Powell. Claudia, if we look at the time, do you think, is there anything else you would like us to discuss?
Hi, Dr. Swart. I think there are, in the chat box, there are, I think there's one more question there. Maybe we can just look at that. And then I think...
No, nothing else in the chat box.
Nothing in the chat box?
No, all of those have been answered. Emergency
Okay,
procedure, you can see whether it's complete. And there's nothing in the chat box, but there's another new one in the question and answer one.
Right.
Another one from Dr. Smith that says, if there's an area of lining left after the ablation, would you consider doing a manual resection of this area?
No, I would, in the end, as I say, it depends on the patient. And all I want the patient to be is happy with what her menstrual loss is like after I've done my procedure. And if she is having some menstrual loss, then yes, excuse me, there must be some endometrium left. And if she's unhappy, I would go ahead and resect that under a general anaesthetic. But if she was happy, it wouldn't worry me. And as I say, the important thing with the thermoblade is the way out of the uterus remains open. So it means I could put in a Mirena, I could take a Powell sample, I could do resections. There's still lots of options open to me for simple, non-invasive management when someone's had a balloon ablation.
Thank you. Claudia?
I think that brings us to the end of the session. I just want to thank both of you for your input tonight and all your time. Mr. Powell, thank you. It was a fantastic presentation. And Dr. Swart, you are a fantastic facilitator. Thank you very much. And I wish you all a great evening further, and we will follow up with all the attendees to find out if all the questions were answered and if they have any further questions. And if it's all right, we will send those questions to you if anything else comes up. That's
my pleasure, and I'm more than happy to. It's been very nice meeting you, Dr. Swart, and maybe we might meet in South Africa one day.
That would be great.
In Nottingham.
Oh, Nottingham, yeah. Well, I don't know whether you'd be interested in our urogynecology though, but we shall see. Okay.
Thanks very much, Claudia and team.
Yes.
See you sometime.
Your health.
Very much.
It's yours.
That's water.
Cheers.
Honestly.
Enjoy. Bye-bye.
Okay.
Thank you.
Good night.
Bye-bye.
Good night.
Thank you, everybody.